Question 31 is saying, concerning malignancies of the thyroid gland, the following is true. First one says, follicular carcinoma usually spreads via lymphatics. The next one, papillary carcinoma, carries the worst prognosis. And then D, we have, it says, uh, spread to the spine is usually hematogenous and associated with a follicular carcinoma. D is anaphylactics. Anaphylactic is usually hereditary. E, medullary carcinoma is poorly differentiated. So we know the thyroid gland has got follicular cells which are going to be making T3 and T4. And then you also have the C cells or the parafollicular cells which will make calcitonin. Now, when you are talking about thyroid carcinomas, you have got four many types. You have got this follicular carcinoma, and then you have got the papillary, and then we have got the medullary. We have also the anaplastic. Okay, at least these are the main ones. Now, when you look at these carcinomas, the first thing we need to know is their frequency. Which one is more common? Which one is less common? So the commonest is the papillary carcinoma. Okay, and then the one that is very rare is the anaphylactic. So papillary and then follicular and then medullary. Anaphylactic is the very least. So papillary is the commonest, anaphylactic is the rarest. Think of P comes later in the alphabet, it's commonest, it has a big number. A, the anaphylactic, is rare. Now when you look at the cells where these carcinomas come from, nearly all of them come from follicular cells except the medullary. The medullary carcinoma originates from the C cells, the parafollicular cells. Now, when you look at for a carcinoma, one thing that determines if it's going to have a poor prognosis or a good prognosis is the differentiation. So those carcinomas that are poorly differentiated actually have got a poor prognosis. So with the differentiation, the one that is commonest, which is the papillary, is going to be well differentiated, including also the follicular is also well differentiated. Okay. And then the one that carries the poorest differentiation is the anaphylactic, which is also rare. So it is undifferentiated. And when you look at the rate of growth, the same one that is undifferentiated is the one that grows very fast. And then the one that the commonest, which is uh, the papillary, is the one that grows very slowly. Okay. And when it comes to the spread, the papillary is going to mostly spread via the lymphatic system to the regional lymph nodes. And then the follicular is the spread is normally via hematogenous and it goes to the bones and also to the lungs. The other one, which is the medullary, the spread can either be lymphatic or hematogenous. And then for the anaplastic, this one, the spread is direct invasion of local structures, and it can also spread by lymphatics and hematogenous. So basically, what we need to know about the spread is anaphylactic and also the medullary can spread via lymphatics or hematogenous. But then for the other two, the follicular is hematogenous, okay, going to the bone. Papillary is lymphatic. Okay. So for the prognosis, we had said earlier that the one that has got which is undifferentiated is the one that carries the worst prognosis. So anaphylactic will carry the worst prognosis. The best prognosis is going to be with the papillary. Okay. which is the commonest, and that's the goodness. It's commonest, but it has got the best prognosis. When it comes to onset, the papillary can start at any age, especially in the young ones, the young adults. And then for the follicular, it's normally in the mid-aged, from 40 years to 60 age. And then for the anaphylactic, the one that is the rare and worst prognosis is more in the elderly. Okay. Follicular, I mean, then the papillary and medullary, they happen in the same age, the young or the middle-aged people. And then for the link with hereditary or heredity, or do we get to get it from by genetics or not? The medullary, there's 25% cases where it is associated with the men 2 syndrome. So there is hereditary characteristic. Anaphylactic, there is no hereditary characteristic. The other two, the follicular and the papillary, can sometimes be gotten hereditary. And then when it comes to the treatment, for the one that has the worst prognosis, the anaplastic, normally that one is palliation. Okay, like you can for the palliation you can do surgery, radiation, or chemotherapy. And then for the medullary, you want to do surgery where you do a total thyroidectomy to remove the gland. And then for the papillary and also the follicular, you do surgery with the radioiodine. So those are the comparisons amongst these different types of thyroid carcinomas. Okay, hope that makes sense. So therefore, with our question concerning malignancies of the thyroid gland, the following is true. Follicular carcinoma usually spreads via lymphatic, and we just said that the follicular one is the one that spreads via blood. The papillary is via lymphatic. B is saying papillary carcinoma has a worst prognosis. This is actually best prognosis. The worst is the anaphylactic type. Okay. And then C, spread to the spine, is usually hematogenous and dissociated with follicular. We said that, isn't it? The follicular, the spread is via the hematogenous and it goes to bones and the lungs. D, anaphylactic, is usually hereditary. And we've just said that there is no relation to heredity for the anaphylactic. The one where we can have hereditary is the medullary. For the other two, sometimes there is hereditary uh, passing from the parents to the children, but it's rare. He is saying medullary carcinoma is poorly differentiated. This is really not poorly differentiated. The one that is more poorly differentiated with worse prognosis is the anaphylactic type. So this one is well differentiated with the others. Okay, so that is it for this one. So the best option is this C. In case there is any question, please let's feel free, or there is any other contribution, we can feel free also to give our contributions. Number 32 is saying, in the 18th and 19th century, a series of eminent scientists laid the foundation of our understanding of homeostasis and the response to injury. Which of the following statements is true? Body system act to maintain internal constancy. Complex hemostatic response involving the brain, nerves, heart, lungs, kidney, and the spleen work not to maintain body constancy. Response to injury are in general deleterious to the host and allow healing or survival. Body systems are inimical to the maintenance of internal constancy. Homeostasis involves a coordinated physiological process which maintains most of the fitful states of the organism. Anyone who can help with this one about homeostasis? I think it's a direct question. Anyone? Okay. Homeostasis. Yes, my good dog, please, you can go on. All right. Yes. Homeostasis is basically about maintaining a constant internal environment. It can either be pH, the temperature, or anything else that you think of where there is need to maintain constant internal environment. So that's why the best one we can pick there is A. Number 32, or is that 3? The neuroendocrine response to severe injury or critical illness involves the following, except neuroendocrine response to severe injury: active secretion of pituitary hormone during the active phase, elevated level of cortisol and glucagon in the active phase, active phase characterized by reduced level of adrenaline, chronic phase associated with hypothalamic suppression, chronic phase associated with low serum level of the respective target organ hormone. So, which of these responses is not there in severe injury or critical illness? Anyone to help with that? Anyone? Would you want to explain, Doc?
There's increased levels of neurotransmitters to active phase.
Okay, maybe just helping someone. Would you say something about the active phase and the chronic phase? Anyone who wants to say something? Okay. So when it comes to when there is a tissue injury or there is any injury at all or an illness, yeah, severe injury or critical illness, you have got the phases in which the nervous system and the endocrine system responds. You have got the active phase, which is also known as the acute or ebb and flow phase. Okay, that's that's active. And these are the phases when you're talking about bends, you also see them there. So the active phase, also known as the acute phase, or the ebb and flow. So what happens here, you are going to have active secretion of pituitary hormones. Okay, for example, ACT, I mean hypothalamic pituitary axis is going to be activated. So what are the hormones that come from the pituitary gland? For example, stimulating hormone. You have got adrenocortical releasing hormone. You have got the luteinizing hormone, follicle stimulating hormone, all those. And then another thing is that because of these hormones that come from the hypothalamus are increased, I mean from the anterior pituitary are increased, it will mean that also they are going to increase the production of the hormones on the glands where they act. For example, you can have high levels of cortisol. Why? Because you have high levels of ACTH. Okay, yeah, so that's what happens. And then in the chronic phase is also known as the prolonged or the catabolic phase. And in this phase, what is happening is that the hypothalamus now becomes suppressed. Okay, it becomes suppressed. So what happens if it is suppressed? The hormones that it produces will be low, And that will also mean that the hormones that will be coming from the pituitary gland are going to be low. Okay. So in the chronic phase again, there's going to be low serum levels of respective target organ hormones because the information from the top is actually not there. So this is what happens. So the best option that we can pick, because remember we want the exception, the one that is not true. So specifically option A is saying active secretion of pituitary hormones during the active phase. That's true, isn't it? Elevated level of cortisol and glucagon in the active phase. That's true. Active phase characterized by reduced level of adrenaline. Now this is going to be false because this is actually supposed to increase. He say in the chronic phase that this one's reduce, and then this saying chronic phase associated with the hypothalamic suppression. That's true. Chronic phase associated with low serum levels of respective organs. That's also true. Number 34 is saying the innate immune system, principally macrophages, interacts in a complex manner with the adaptive immune system in co-generating the metabolic response to injury. Or but one of the following are examples of pro-inflammatory cytokines. Okay. So which of these is an example for a pro-inflammatory? Okay, they say oh but one of the following are examples. Which is that's English, huh? Oh, so meaning we want an exception, which one is not a pro-inflammatory cytokine. Interleukin 1, tumor necrosis factor alpha, interleukin 6, 8, T cells, B cells. Which one would we pick for this one? Okay, it's isn't it? Yeah. The pro-inflammatory cytokines, what happens in inflammation? Interleukin 1, 6, 8, and tumor necrosis factor alpha will be produced. T cells and B cells are really not cytokines. Okay. Number 35. What range of energy expenditure above the predicted healthy resting value is expected is experienced by the majority of trauma patients? What range of energy expenditure above the predicted health resting values is experienced by the majority of trauma patients, except possibly those with extensive bends? 5 to 10, 15 to 25, 5 to 8, 8 to 10, 12 to 18. Any thought on this one? Anyone to help? Okay. So for people that have got, except those that, of course, with extensive bends, most trauma patients will experience an increase in energy expenditure, like the energy that they have to use, approximately 15 to 25% above the amount of energy that is used by a healthy resting uh, man. Okay. And this elevation of this temperature or the energy that the patient is using, who is a trauma patient, is because after this trauma someone is going to go into what we call the hyper metabolic state. Okay. So hypermetabolic state is basically the response to injury. Someone injures themselves, and so that's why even the energy that you are using is a lot than the usual normal. Okay. So what really happens here, uh, the body is going to initially after trauma, the body is going to enter what we call the catabolic state. It will start breaking down things, that is trying to mobilize energy. to support the immune system, to heal the wounds, and for the organs to be able to recover from the injury. So what happens is that there's going to be high levels of stress hormones like cortisol and catecholamines, and then there's going to be a breakdown of proteins, including also muscle, and then there will be a lot of production of heat. Okay, so that is what happens. And then, but what happens in extensive burns is that expenditure of energy is going to increase even up to 100%. You literally use up everything. Okay, and that is what distinguishes it from a typical trauma patient. Because in severe burns, you are using up nearly even all the energy. I don't know if there's a question on that one or a contribution before I go on. Number 36, the water mass of an average 70 kg male is 42 liters. What is the composition of intracellular and extracellular spaces? Sorry, 15 to 25%.
Then the one you said it can be close to 100 is we're
It's
talking about that one for Ben.
yeah, yeah. For the extensive bends, the energy that we normally use is going to be different in someone with extensive bends, because in extensive bends it can increase even up to 100%.
Thank you.
All right. So, what is the composition of ICF and ECF? Anyone to help with this one in an average 70 kg adult male with 42 liters as the total body water? Anyone? Now, this is something from our physiology. Remember what we call the 60, 40, 20 rule? So, an adult male, because for female the water is about at 50%. So, total body water is 60% of the weight, and then 40% is actually going to be inside the cell. It says 40% of the weight, the fluid is inside the cell. Then 20% is outside the cell. Now, for an adult male, the total body water, since it is 60%, so it's going to be 60% of the weight. And the weight is, we consider 70 kg. So when you multiply 60 out of 100 times 70, this gives you 42 kg. Now the density of water is 1 kg per liter. So you multiply this value by, in 1 liter, you basically have 1 kg. That's the density. So it gives you 42 liters. Now of these 42 liters, you can use the 60 40 20 by saying ICF is actually 40% of the weight, which is 70 kg. And this is going to give you 28 liters. For ECF, it is 20%. These are values you can just know in the brain, without even punching. 20% of 70, and this is going to give you 14 liters. Hope it is okay. Are we okay so far? Contribution or questions? All right. So it is 28 liters intracellular and 14 liters extracellular. So that is option A as the best option. The next question, 37. Which of the following shock is caused by a reduced circulating volume? Cardiogenic, obstructive, distributive, or all of the above, none of the above? Anyone to help with this question? Anyone?
faint.
Sorry?
I think it's faint.
Why?
There's a percentage of widespread vasodilation, and there's increased vascular permeability, so really there's reduced plasma volume.
All right. Okay. Thank you so much, my good doc. Yeah. So when we are talking about these different types of shock, we have got hypovolemic. We divide them into, is it four main categories? Hypovolemic, where the problem is that there is a reduction in circulating blood volume. The clinical features, the peripheries are going to be cool, rapid heart rate in compensation and such. What are examples that can cause hypovolemic shock? Hemorrhage, for example, from trauma or GI bleeding, severe dehydration may be coming from vomiting and diarrhea, and severe burns. This can cause hypovolemic shock. As we go out of this discussion, I want us to go and look at what we call third spacing, the concept of third spacing in burns. And then we have got cardiogenic shock, where the heart itself is fed into pump. So the features will basically be the same, but besides the cold and the cool, clammy peripheries or skin, and then the rapid heart rate, because it's cardiogenic, someone might have symptoms of heart failure, like crackles in the lungs and jugular venous distension. So what causes cardiogenic shock includes things like myocardial infarction. In an heart attack or arrhythmias or heart failure or cardiomyopathy, the heart cannot really push blood forward, and that's what is causing the problem. And then we have what we call distributive shock. Now, distributive shock, this is just where there is, it's distributive, the entire body, there is widespread vasodilatation. And what is happening is that the capillaries, because of this vasodilatation, they also increase the permeability. And what does that make that do? It leads to misdistribution of blood volume, misdistribution. It will start going to wrong places. Okay. So for the signs, early on, you can have warm peripheries. The skin can be flushed initially. Why being flushed? Because the blood vessels have dilated, so a lot of blood is actually reaching the skin, and so it looks flushed or red. And then later on, they can be now these clammy, cool skin with rapid heart rate and low BP. So I've got different types of distributive shock. You can have septic shock due to infections. Okay, this can lead to dilatation because of the cytokines that will be released. And then they can also just be anaphylactic shock or allergic reaction. They can also be neurogenic shock, where someone has got a spinal cord injury that can result also in this widespread vasodilatation. The last type of shock is the obstructive shock, where there is a physical obstruction to blood flow either back to the heart or away from the heart. So, what are some of the examples that can cause obstructive shock? Things like pulmonary embolism. There's basically a physical obstruction, tension pneumothorax, cardiac tamponade, where I've got blood in the pericardium, so the heart cannot really contract to push away blood. So all those are causing obstruction. Okay, so we have to be aware of that. Is there any question on this before we can go on? Any question or addition? Now remember, we've talked about this obstructive shock, saying that there is cardiac tamponades, where you have got blood in the pericardium causing the heart not to contract, can be a cause. Now, cardiac tamponade has got a triad, which we call the Beck's triad. Anyone who can help us with the Beck's triad? Anyone? What are the components of this triad? Okay, with the components, remember you can't push blood forward.
Although it's like I think
Yes, doc. Uh-huh.
yeah, basically
hmm
just another one.
Yeah, thank you so much. Mhm. So there's hypotension because the heart can't really push blood. So hypotension, blood will start going backwards. That will lead to jugular venous distension. And then there are these muffled heart sounds because fluid has piled up in the pericardial sac. Okay. And because of this, a lot of fluid in the pericardial sac, when you put your stethoscope on the chest, that fluid acts as an obstruction to the transmission of sounds, and that's the muffled heart sound. All right. Number 38. A 32-year-old female underwent subtotal thyroidectomy for symptomatic euthyroid goiter. During the postoperative review, she was found to have a swelling on the surgical site secondary to hematoma. Necessary interventions were taken to correct this. What is not true about reactionary hemorrhage? A delayed hemorrhage within 24 hours, dislodged or clot by resuscitation is one of the causes. It usually occurs 7 to 14 days, can be caused by normalization of blood pressure and vasodilatation. Reactionary, reactionary hemorrhage may also result from technical failure, such as slippage of a ligature. Anyone with a thought on this one? Anyone? So we want a statement that is not true about the reactionary hemorrhage that might result into this mass that is present. Anyone? All right.
So but you can't see your screen. I don't know if it's on my end, but I can't see your screen. But someone look at the screen, see, you know what to see. I don't see
Okay.
any other thing.
Uh, I don't know. Are there? Is there anyone who can see the screen?
Yeah, I
Okay.
don't see the screen.
All right. Okay. So for reactionary hemorrhage, anyone
But
who wants to say something? Okay. So for the reactionary hemorrhage, this is bleeding that is going to occur after surgery, and normally it is going to be within the 24 hours. What really causes this bleeding is after the initial hemostasis or the clotting has been achieved, that's when this one gets to happen. Okay, the bleeding after surgery, after the initial hemostasis or the initial clotting, It's actually divided into the primary and secondary. Primary occurs during surgery or immediately after, and then the secondary is the one that occurs uh, after 7 days. And normally it doesn't just happen, but it's going to be due to an infection, or maybe there's a problem in a vessel wall. So that is what happens. So when you look at the options that have been given, A is saying is delayed hemorrhage within 24 hours. That's true. B saying dislodgement of clot by resuscitation is one of the cause. Now that is also true. Let's say like what happens is that after surgery you are forming this close to the body is forming this close to prevent bleeding. But then maybe during resuscitation, okay, or coughing, you end up pressing on these clots and then you dislodge them. So that can actually result into it can trigger bleeding, okay, because you've removed the cloth that was protecting the area. And then she's saying can be caused by normalization of blood pressure and vasodilatation. That's also true. Remember what happens, the initial thing that happens when there is injury, there's going to be constriction of the vessels, and that is in an attempt to stop the bleeding. So vessels that were initially constricted during hypotension may end up bleeding when the BP gets to normalize. Okay, so can be caused by normalization of BP and vasodilatation. That one is true. When the BP comes because after some you have got this injury that has happened, or maybe after the surgery there's some form of loss of blood and then the BP has dropped. So when the BP is restored, it basically means that it becomes higher, and that can lead to these clots. Okay, I mean to this bleeding. And then is the option C. I didn't talk about it, but option E saying reaction hemorrhage may also result from technical failure such as slippage of a ligation. And that's true, isn't it? Because if the ligation that you made, like when you are suturing and such, there's a problem, it can actually lead to hemorrhage of this bleeding. But for C, it said it usually occurs 7 to 14 days. So that one, the 7 to 14 days is for secondary hemorrhage. All right, not really the reactionary hemorrhage, which is happening there and then without it within the first 24 hours. So the best option we can pick is this C. That's the first one. What is the blood volume lost as percentage of total in patients with class 3 hemorrhagic shock? Less than 15, 15 to 30, 30 to 40, 40 to 45, greater than 45. In class 3 hemorrhagic shock, anyone to help with that?
Could you just use what that was your screen?
Okay, again, there is another doc who can see. Are we able to see those that can? I don't know if there are some who can see.
Yes, we can, sure. Let me try to look out and when you what you again. Let us
Yeah,
see.
in case we can't see, just try to log out and then log in. Okay, all right. Now, before we even talk about the amount of volume that is going to be lost in shock, hemorrhagic shock, we can classify hemorrhagic shock into class 1 up to class 4. And there are different parameters that we use when you are talking about these classes. There are different ones. For example, the first parameter I can talk about is the amount of loss of blood. In class 1, we've just lost about 750 mils. Okay, that's in mils. In class 2 is between 750 to 1.5 or 750 to 1500 mils. Class 3 1.5 to 2 liters. And then class 4 is more than 2 liters. So I've got 750 mils, 750 to 1.5 liters, 1.5 to 2 liters, and then more than 2 liters, that's class 4. But you can also look at the blood loss as a percentage. In class 1, as a percentage of the blood volume. In class 1, less than 15% of the volume is going to be lost. In class 2 is 15 to 30%. In class 3 is 30 to 40%. And then class 4 is anything more than 40%. The other things that we look at, such as the heart rate and also the BP, like in 1 and 2, the BP is normal. In 3 and 4, the BP is decreased, though in 4 it is really, really, really decreased because you've lost a lot of blood. And then you can also look at the pulse pressure. In 1, it is normally normal or it can be even high. And then in the others, it is actually decreased. Now in 4, it is very, very decreased. That's a pulse pressure. The capillary refill, again, you can look at that. In 1, it can be normal, less than 2 seconds. And then in 2 and 3, it can just be delayed. And then in 4, it is not there. The respiratory rate, remember, if someone has got shock, the body will be trying to compensate. So in 1, like the respiratory rate is normal. In 2, it is increased. If I say normal, is normal between the 12 to 20. In 2 is 20 to 30. In 3 is 30 to 40. And then in 4 is more than 40. And then also urine output. Because someone has got shock, they've lost a lot of fluid, so the body is trying to stop the urinating a lot. So the urine output in mils per hour, in class 1, it's more than 30 mils per hour. Class 2 is between 20 to 30. Class 3 is 5 to 15, and then it's negligible for class 4 because you've really lost a lot of blood. You can also look at the mental status, where running from being anxious to being lethargic for class 4. And then when you're talking about the fluid replacement in class 1, you basically use crystalloids in 1, 2, and 3. Actually, in all of them you can use crystalloids, but in 3 and 4 you can add blood. Okay, so that is the classification of shock. So for this question is saying in class 3, to be specific, the percentage of blood that is going to be lost. We said you have got less than 15, 15 to 30, 30 to 40, and then more than 40. Those are the values. So this one is 30 to 40 because it's class 3. Okay. 15 to 30, that is class 2. Less than 15 is 1. And then more than 40 is a class 4. What is a neonatal radiography showing the double bubble sign diagnostic of? This is the thing they brought, isn't it? Okay. Anyway, let's forget about that. So the double bubble sign diagnostic of anyone? The double bubble sign, what does it show? Sorry? Any thought? Okay. The double bubble sign is a sign for duodenal atresia, right? The duodenal atresia. That's a double bubble sign. Mm. If you remember from the OSC. And how does it look when you look at the X-ray? You will see so it's a transverse colon where you have got just a dark area. But that's a double bubble sign for duodenal atresia. Number 40, 41. A 60-year-old man presents with non-painful, non-rectal bleeding secondary to rectal tumor. CT shows the tumor invades the submucosa with no regional nodes, no distance metastasis. What is the TNM classification? Anyone who can help? Let's feel free, doctors. Let's feel free.
D.
Okay, how have you come up with D?
Ghana said Ghana invaded the submucosa, so that's C1, and then there's no regional lymph node involvement, so that's M0, and there's no distant metastasis, so that's M0.
All right, thank you so much. Is there anyone that has a different thought? Okay, thank you. So just maybe something to review. Just I think what's important is on the metastasis. We know if there's no metastasis, that is zero. If there is one, and then for the nodes, you look at how many nodes have been involved. So when you're looking at the tumor, which is a T, you can have, if the tumor cannot be evaluated, you put TX. If there is no evidence of primary tumor, you put to T0. And then if you have got carcinoma in situ, that's the one you put TIS. And then now when you look at the size or extent of the primary tumor, for example, highest number indicates a number, a larger tumor. So that's the one you use T1, T2, T3, T4. That's to talk about the size. For the N, which is the lymph nodes, if you put X, it means that you can't evaluate the lymph nodes. Basically, X means can't be evaluated. N0 node lymph nodes. And then I've got N1, N2, N3, telling you about the involvement of the regional lymph nodes. For the metastasis again, you have got the X, meaning that distance metastasis cannot be evaluated. M0 is no distance metastasis, and then M1 is going to mean distance metastasis is there. So that is how you can talk about this TNM staging. So meaning for this one specifically, uh, again for the tumor, the T1 and T2, you look at which area has been invaded. T1 means there is invasion of the mucosa. T2 invasions of the muscularis propria. Okay, so that is the tumor. So for this one, there is a mucosa that is going to be T1, isn't it? And then no regional lymph nodes N0, no metastasis M0. So that gives us that's B. Oh, sorry, D. Number 42 is saying the agenda for medical education and clinical governance requires doctors to expand their skills to encompass audit and research capabilities as useful tools for continued outcome measurement, service improvement, and innovation for the benefit of patient care. Audits are formal processes that require a structure. Which of the following steps are essential to establishing an audit cycle? Is this surgery? Define the audit question in a multidisciplinary team. Identify the body of evidence and current standard. Design the audit measure. Performance against agree standards based on strong evidence. None of the above or of the above. Any thought on this? I don't even know if it's surgery or it's DME. its com skills. Anyone? Let's feel free with any contribution, just anything.
Let's see.
Okay, E. All right. Thank you so much. Now, again, let's look at this question. Okay, they're asking about the steps essential to establish an audit cycle. So, in establishing an audit cycle, you can define the audit question. What are audits really about? Uh, Anyone who can define for us, even from the English perspective, audit. Okay, basically you want to see like how things are being used. That is auditing. How things are being used, if they are being used rightly, and to see in case there's any misuse, you get to come in. So the first thing is you are going to define the question. Yes, you define the audit question. Okay, and this question must be number one. It should be of clinical priority. Why are you even defining this question? To see maybe there's a problem that you've noticed. Maybe there's misuse somewhere. So that's why I want to come in. And then you also identify the body of evidence and the current standards. Okay. So audits must be grounded in best practice guideline. You look at the clinical standards so that the performance is measured against credible and accepted the criteria. For example, if you say what you have done is not what you should have done, what criteria are you using? Okay, there should be evidence and current standards that you are comparing to that people failed to meet. And then three, saying design the audit to measure performance against the agreed standards based on strong evidence. And that's true, isn't it? Okay, the whatever edit that you are designing should be measured against the standards, and then there is evidence. So the answer here is all of them. 43 is saying a 22-year-old female Zambian football player was injured by her opponent and sustained a the this was supposed to be what wound on her left leg while playing at the World Cup. Her wound appeared to be healing, normally mild erythema. What is the Southampton wound grade of the wound? So here the wound is being described healing normally and then mild erythema. Anyone who can help with that? Anyone? Okay. So the Southampton wound grading system is going to assess surgical wound healing and also the complications of this wound healing. Okay. So there is a healing wound. Now, for the grades, we have got from grade 0 up to, that's a 5. 0 is when you have got normal healing with no inflammation. 1, there is a mild erythema or bruising only. 2, there is erythema and a discharge. 3, there is a purulent discharge. 4, deep or severe wound infection is there. And then 5 is wound requiring surgical intervention. So that's the grading here. So for this one, it has just erythema, so that is 1. Okay. A 64-year-old man is being investigated for an upper gastrointestinal disease and is scheduled to undergo esophagogastroduodenoscopy (OGD). However, the patient is also being managed for deep venous thrombosis of the right lower limb and is on warfarin for a month. What is the appropriate measure prior to the OGD in this patient? Discontinue warfarin 3 to 5 days before the procedure and may be resumed the night of the procedure. Discontinue warfarin 2 days before the procedure. Discontinue warfarin 2 days before the procedure and may be resumed 2 days after the procedure. Discontinue warfarin hours before the procedure. Discontinue warfarin 3 to 5 days before the procedure and may be resumed 3 to 5 days after the procedure. What do you think on this one? Any thought?
Mm.
Now, when you are doing this gastroesophageal duodenoscopy, because you have got this instrument that is entering the body, the chances are that you can actually injure some structures or you can actually cause bruising that can lead to bleeding. So, in a patient where you have got, okay, sorry. So, for patients that are on warfarin, this is an anticoagulant. It means that if there's any laceration, right, as you are putting this OGD, bleeding is going to be profound because the natural body doesn't have a mechanism to stop that bleeding, right? And for warfarin, how does it really work? Warfarin is going to, the mechanism of action, it will stop the production of these clotting factors. And for it to consume, so it takes about 3 to 5 days for it to start working. And the reason is because that's the time it takes the clotting factors that were produced to finish. Okay, to finish. So meaning that if I give warfarin today, I don't expect the effect to start showing today, 3 to 5 days from now, because you already have clotting factors which were produced today, and those clotting factors will take 3 to 5 days for them to be dead or to be used up. But then after you are done, after you do the procedure, you can put the patient back on warfarin, okay, immediately. So the best answer you can pick is A. Discontinue warfarin 3 to 5 days before procedure and may be resumed the night of the procedure. Number 45. After undergoing upper GI endoscopy, 59-year-old man is being suspected to have esophageal perforation. Which of the following is true about symptoms of endoscopic esophageal perforation? Frontal headache and tinnitus, neck or chest pain, surgical emphysema, only B and C, only C. Any thought on this one? A complication of esophageal perforation. Anyone, please feel free to contribute any thought that you have.
I think more like I would say because I would say let's say there's not damage to that system because sometimes That's a correct job.
All right, thank you so much. Yeah, when you are putting this machine now, but it, by mistake, it ends up going into the lungs, right? That can cause injury and this emphysema. Okay. And then for the pain, yes, this is it's not really an invasive procedure, but this is a something that is entering into you, so that can cause the pain in the chest. Right. Number 46. So the answer is B and C. A 28-year-old woman underwent wide ex wide loc wide local excision of a 5 centimeter long standing tumor on his right leg. Okay. The a histopathological report was suggestive of malignancy. What are the microscopic features of malignancy? Metastasis, perineural and vascular invasion, architectural abnormalities, or the above only C. So, for a malignancy, what are you going to see on the microscope?
Okay.
Or do you want to explain, Doc?
Um, yes, you can hear metastasis if it's present. Then malignant it usually cause vascular invasions and also have abnormal cellular growth, so there'll be architectural abnormalities.
All right, thank you so much. Yeah. So, features of cancer metastasis, which you can see, of course, with the lymph nodes involved or the distant organs, perineural and vascular invasion. So, the malignant cells can actually infiltrate into the nerves and the vessels, and that can be seen. And then architectural abnormalities, for example, disorganized tissue structures, loss of the polarity of the cells. Normally, a cell is going to have the basal pole and the apical pole. There can be loss of that, even abnormal gland formations. All those are architectural abnormalities. So it's C of the above. 47 is saying there are various risk factors and scoring criteria for thrombosis in surgical patients. Reversible risk factor for thrombosis should be addressed before elective surgery if possible. Which of the following is a moderate risk of thrombosis? Major surgery, major surgery, trauma or illness in a patient, lower limb paralysis or amputation, major surgery, no risk factor, less than age of 40, major surgery, age of 40 plus, or other risk factors. Anyone with this thought on this one? Any thought? Feel free to contribute anything.
Um, Sorry, Doc, I have a question on the previous question.
Yes, Doc.
Yes, the question was saying, what was the microscopic features? I didn't get the explanation on metastasis. How can you tell metastasis on the microscope? I'm behind on this one.
Oh, the microscopic features.
Yes.
Okay. Anyone that wants to help, like for metastasis, let's say the cancer went to the lymph node. When you take that lymph node, you can look at it on the microscope and it will confirm if the cancer has reached there. Or let's say there's an organ you're suspecting has a metastasis from another region. If you take that organ, you can look at it on the microscope. If you see the cancer there, that can confirm the metastasis. I don't know if that makes sense.
Okay, yeah, that makes sense. I thought my thinking was just based on the cancer itself. Like you get the biopsy from the cancer itself into the disease, when it's getting more, then you can be able to tell. That's how
Oh, okay, all right. Thank you so much. So, how about this question, which is present here? Which one is a moderate risk factor for thrombosis? So, for the risk factors of thrombosis, uh, okay, anyone that wants to say something? So, we have got major surgery, for example, elective or trauma, orthopedic or cancer, or the pelvic, hip, or lower limb. Then major surgeries, trauma or illness, lower limb paralysis or amputation, major surgery more than 30 minutes, no risk factors less than the age of 40, major surgery like no orthopedic or abdominal cancer, age 40, or other risk factors. So when we look at this one, for the moderate risk factor, is going to give us some percentage of developing. You have got only a little percentage of developing thrombosis. Yeah. So you classify these risk factors for developing thrombosis into the high risk, the moderate, and then the low ones. For example, on the high risk, you have got things like major surgery or trauma in a patient with a personal or family history of thrombosis. And then you also have major orthopedic or cancer surgeries, or the pelvis, the hip, or the lower limbs. On the intermediate, that's where I've got a major surgery, which is not orthopedic or cancer related, in someone who is aged 40 years or more. You also have major surgery with additional risk factors. For example, someone has a major surgery with obesity, maybe they have got some more thrombophilias. Okay, so that's a moderate. Major surgery, which is not orthopedic or cancer related, with for more than 40 years, or a major surgery with other risk factors. The high risk, this includes like major orthopedic surgeries with a family history, or maybe major orthopedic surgeries of some important bones like the pelvis, the hip, and the lower limb. The low risk, the low one includes major surgery more than 30 minutes in a patient who is less than 40 years, with no risk factors at all for developing this thrombosis. Okay, so that is that. So here we can say, okay, that's high risk. So it's E, major surgery in someone who is 40 years with other risk factors. Number 48 is saying, what is the most appropriate anesthesia useful in a limb or obstetric emergency when the patient is not starved and gives good postoperative pain relief? Local, general, regional, only A and C, or except B. What do you think on this one? What is the best anesthesia we can use for, let's say, an obstetric emergency, or a limb anesthesia, someone that ate food. And remember, why do we tell patients who are going to theater not to eat, preventing aspiration pneumonia? Some This tells us that whatever that we are trying to do for this patient, the anesthesia shouldn't go and reach the lungs or maybe the diaphragm, so that there'll be no aspiration. So here the best thing that we can do is use a regional anesthesia, so that it just deals with the region that we're interested in and not everywhere else. Okay. And then 49, a junior resident medical officer working in the accidents and emergency department of a tertiary hospital attends to a 20-year-old male patient with strangulated right inguinal hernia. What preoperative preparation is not true before surgery is undertaken in this patient? The patient's identity should be confirmed, and the patient should be asked to confirm what surgery is being carried out. The patient should consent to undergo surgery. All relevant results, investigations, and imaging must be available. Check for any sepsis is unnecessary. The side to the operated, the side to be operated on should be marked with indelible pen. Any thought on this one? When you look at option D, the other ones are confirming what we do for a patient before taking them to surgery. But D is saying check for any sepsis is unnecessary. You want to know if someone has got widespread infection. That's important, right? And then for the last question for now, a post operative patient developed a surgical site infection on day one post repair of a reducible left inguinal hernia. The following are possible external sources of contamination in the operation theatre, except poor scrubbing up, gowning, and gloving technique, excessive inappropriate movement into and out of the operating room, restricted number of people in the operating room to the surgical team only, unnoticed perforation of a glove, contamination of instruments by scrubbed person. So which of these is not a method of contamination in the operation room?
mm,
Sorry?
mm,
Okay, restricting number of people in the operation room to surgical team only. Okay, so that one might not be true, isn't it? So restricting the people will not really get to be the biggest cause or the preventative measurement to contamination. But the other things that have been given, for example, an notice perforation of the gloves, are going to cause this perforation, or be not just the perforation itself, but restricting the number of people in the operation room. Well, if there are too many people, of course, might be a problem. But people that come in the operation room, they come uh, prepared for sterility, like on the scrubs and everything else. So this will not be a major problem when it comes to contamination.